So to start us off, the main reason as to why we had this session was to cover the aspect on reproductive health, sexual reproductive health and rights advocacy in the period of COVID-19 outbreak. So when we're looking at sexual reproductive health, we find like there are so many civil society organizations, community-based organizations, and even some of the NGOs that have been working on issues to do with reproductive health. And majorly these organizations at this point in time, they're not going to do much because of the disruption that has been there with COVID. And some of them are now repurposing their agenda to go into addressing COVID issues. So you find like, for an example, one of the organizations might be out there giving people education about prevention measures about COVID, which is a good thing. But the question is, what happened to their in-house projects that they've been running? If you've been more active on sexual and reproductive health and rights advocacy, then it means that is the kind of work that you should be aligned to. Even when you are going out of that, you should be having a backup plan on how to pick it up when you're done with the sessions, let's say with the COVID actions. But then the question is, if you stop, chances of coming back might not be that easy. And two, you need to stay relevant within your area of work. So how do you ensure that you stay relevant when we are dealing with a situation that is not it's not a normal thing, and we have to find a way to cope with it? So that is what we are looking at this point. So that was the reason we came up with this aspect on now sexual reproductive health, and it's going to be part of our Ryculture CSOChats. That's the Ryculture Civil Society Organization chats. We'll be talking about reproductive health, sexual reproductive health and rights today. Then we have so many other sessions that are lined up. We'll be having a session on mental health. We'll be looking at issues on unemployment, because there are people who've been working on the unemployment area, people who have been working on capacity building, migrants and refugees health and related issues. So once we get to that point, we'll be assessing it in terms of what extra value can we give these people, and what extra value can they gain by repositioning themselves in the advocacy space to make an impact. So once that is done, we'll be moving ahead now to the next phase, where we look at it in terms of, we are past COVID. How do you make yourself like post-COVID? How do you make your programs be more efficient, achieve the impact, and ensure they're sustainable, such that in case we ever get to a point that we have such a pandemic, you're able to respond in the best way possible? So that is what the scope of what we are looking at. Our work before, during COVID, and what makes us stay relevant and even succeed post-COVID as civil society organizations. So that is going to be the scope of what we are looking at this point. So to start us off, we're going to start from the point of the introduction on what sexual reproductive health and rights are. So these are efforts that are aimed, actually when we talk about advocacy, this is to champion, to promote a particular cause. So it's our efforts aimed at preventing preventable maternal and neonatal mortality and morbidity, death and sickness because of for the kids and mothers, which we can prevent. That one we'll look at. Then we go to the next extra age on looking at how do we ensure there's access to quality sexual reproductive health and services. And when we address access, there is availability. The sexual reproductive health services must be available, and they should be available. So once we know they are available, then can people access them? And especially when we look at sexual reproductive health, mostly been focusing on the youth. Are the youth able to access those centers? Are they youth friendly? If you get to a facility that when you ask for contraceptive materials, you're going to be judged, chances are most of the young people will not be willing to go for the services. So that is a challenge. So if we can go to a point that now we have bridged the gap and they are able to access them because they're youth friendly, that is a bonus point to us. So they're available, they're accessible because of the issues, then affordable. If you tell someone, for example, in the campus setting where most of young people we are, let's say in the age group of 19 to 24 and in the universities, you tell them a contraceptive material would be going for, let's say, 5,000, chances are most of them will not be taking using the services. So if they can't use them, however much they're accessible and available, they're not affordable. So those are issues that we look at in terms of access. Then also we address the sexually transmitted diseases, including HIV. We have cervical cancers that are also there. We have to look at them because they affect our sexual reproductive health. Then there is the violence against women and girls. And then we have menstrual and menstrual hygiene related issues. So when we look at it in SRHR, we have to ensure that people are able to have safe sexual experiences free from discrimination, coercion, and violence, and they're able to choose if, when, and how often to reproduce. And that brings us to the other component where we talk about abortion. So that is a critical thing when you're talking about SRHR. So when we look at it now, from this perspective, we have different focus areas that different civil society organizations and NGOs have been focusing on. There is the gender-based violence, we have menstrual hygiene management and health. All these are disrupted, and I'm going to look at it in terms of the disruption now. In gender-based violence, this is a point that now even reports that we've been receiving, there are pointers that gender-based violence is heightened. Reason, if you had an abusive husband or an abusive wife, because of the stay at home and the lockdown that has taken place, now you are within the same confined environment. Every other thing that you do, familiarity brings contempt. So you get to see this person, the bad things they do, and they're used to, the only way that they can resolve these issues is through fighting. So when it gets to that point, gender-based violence gets heightened. Then we go to the menstrual hygiene issues that are there. Menstrual hygiene, most of the young ladies who are not able to get the menstrual hygiene material, the sanitary towels, tampons, and all that, most of the distribution has been through the different schools where they study. At this point, the first response when the first case was reported was to close down on all schools and learning institutions. So when the learning institutions are closed, these are ladies who have been depending on the school programs and different NGOs who interact with them through the schools to give them the reproductive health materials. How do they cope when they are home? Nobody will be able to give them the reproductive health materials, the menstrual hygiene materials. So it means their hygiene measures are compromised. The education they're used to getting is not there. And these kind of talks are not normally just for menstrual hygiene specifically. They have menstrual hygiene, but they have the kind of motivational speaking, kind of the guests who come on board, sexual education, and all that kind of information. It means at this point in time, they're not able to access these services, and that affects them as individuals. Then we get to the next phase, we have contraception and family planning. Condom dispensers and all that, they've been the universities, let's say now for the university students, they've been given through the dispensers. Now when people are home, nobody will ever install a dispenser in your home or in your house ever. So those are some of the challenges we're having. Family planning, people used to go to for them in the hospitals. With lockdown, going to hospitals, even for the sick, is a problem because you fear you might get infected when you go to a hospital. So if that's the case, how do you ensure they have access to these materials? Generally, even getting the, let's say, the intrauterine devices, the injections, the patches, and all that, getting them was not that easy before the corona wave came in. And that's why we had so many organizations coming in to do advocacy, to educate the masses about their benefits and discussing the options that women have. At this point, they are not being done as much. So it means penetration is not as much as we wish it would have been. And beyond penetration, we are at a point where now even the penetration can't happen. We can't enlighten people about it because we are working from a point of challenges already. COVID, we restricted movement, restricted education, and all that. So getting the people the platform to engage with them is a challenge. Maternal neonatal health. I remember there's a point last week, but one that I had. There's a lady who wanted to give birth, and because most ambulances had been repurposed to help in transferring COVID patients, COVID-related patients, then this woman had to make different alternative arrangements to be taken to a hospital. I'm hoping she got delivered well and was helped to the point that now everything is okay. But what happens for people who've been advocating for this, people who've been ensuring they have access to these services, and now with COVID, everything has been repurposed. It means some of the women will die because of preventable maternal, like pregnancy complications. Children will die because nobody's going there to take care of them, especially now because in the cold season, risk of pneumonia development is higher. So those are complications that are going to come up, but the things that are preventable. How do we look into such? We have FGM, female genital mutilation. Communities, some of them will still continue practicing FGM. The question is, what interventions do we have? Because even now the surveillance and issues on FGM are limited. People are more focused on COVID. Any coronavirus patient, or any person who has escaped, any strange person getting into your community, those are the people we are looking for. Do we take time to look into FGM related activities? And some of them are being coordinated by their very immediate families. So you might never know because they're done within the house. in terms of access to safe abortion, that is now we have the pro-life and the pro-choice debate. Generally, abortion services are inhibited, are prevented. But now, at this point in time, one, as we mentioned, gender-based violence is on the hike. It means even rape cases are going to be higher, forced sex and all that, those are going to be there. And when such happen, chances are they are not protected sexual encounters. And then when they're not protected sexual encounters, chances of getting pregnant are there. And being now we have young ladies who are their homes and all that, the women who are in their villages, they're staying with their people, very chances are very high. Some will get pregnant. They're pregnant not out of choice, because when we're talking about the choice, it comes from the point of deciding if you want to want to have sex, when to have sex, whom to have that sex with, whether you want to have a child or whether you don't want to, and then how you're going to have your sexual encounter with that person. So at this point, being they're going to be forced, the rape and all that, sodomy, it will get to a point that their abortions will going to be high because I was forced to have sex with this person because of the circumstances under which we are living because of COVID. Then how do we help them ensure that for those special cases that we have provided for, they can get access to the reproductive health, the abortion services, safe. But at this point now, because of the lockdown and everything, they might not be able to get those services when they need them. HIV/AIDS and STIs, access to services, especially for HIV/AIDS patients and even the STIs, it has been through different programs that are run by the public health institutions. At this point in time, most people are not even willing to go to the hospitals. If they're not going to access a hospital, it means chances of getting their medications will be reduced. So how do we ensure they get them for people who've been advocating for them? And another challenge when we talk about the medicines now is finding them within the facility. Some hospitals will not be able to stock them because even transportation of different cargoes and all that has been reduced, and even importation is a challenge. So if we've been relying on importation from other countries, we want to be having these products within the country, and that is a hindrance that we have. Other programs, cervical cancer treatment, endometriosis, breast cancer, and all that, the treatment plans are supposed to be going on, but even the screening, because before we treat someone, we need to do the screening. And there's a time we used to have the mass campaigns where we had the testings that going on and all that. Now these are not going to happen because mostly we have locked down, we stopped on any public gatherings. So any person who might be at risk, who have never been tested, might not be tested. And when they're not tested, that's going to affect the outcome of the services that we're delivering. Then now the operational workbook, what has the SRHR communities advocacy groups been doing? We've been focused on health communication and education, supply of sexual reproductive health materials. I remember there's a point we were at MKU with the DNK, we had Maristops, we had different organizations. They were giving the reproductive health materials. Now we are not able to get them. Ensuring services are there. Maristops have been working on ensuring people have access to contraceptive materials. We've had Sexual Reproductive Health Rights Alliance. They've been giving access to these services through their different members of the platform. Now at this point, they are all locked down. There's lobby groups for improved access to sexual reproductive health that's covering affordability, accessibility, and availability. So there are lobby groups that have been doing their work. At this point, every lobby group is focusing on COVID. Because even when you look at sexual reproductive health, when the government is looking at it, is ensuring people have access to the services, especially now with focus to COVID. What about issues that were not going to be affected as much with COVID, but are related to SRHR that will affect the quality of people's lives? We have to look at them. Then representation of disenfranchised, abused, or molested individuals, especially people who've been raped and all that. They have the different representation of groups. For example, in Kenya, we have the KELIN group. It's an advocacy group. And they've been looking at representing the people who've been abused and all that in courts, seeking justice for them, linking them with different homes and all that. And now at this point, chances are even the people who are abused, they can't report because they're within an enclosed system. And in situations where they're not in the enclosed system, they are not able to come out and say what challenges they are going through. Because even now, the risk is you're being abused in your own home setup. When you leave, you'll be exposed in the out. And most of it because some people are like, the abusers are, some of them are rapists and they don't stay within the houses as much. in certain situations. So you meet someone out there who will also take advantage of the situation because you've run away from your home. You need someone to host you. Then that person acts like your savior. It's a savior in quotes because this person is not there to save you. They are there to take advantage of you and use you again, exploiting you. So these are representations that the disenfranchised groups that are there. How do we ensure they get the support they need? Community engagement, sensitization, and behavior change designing and implementation. Majorly, that one goes in terms of FGM related issues because we need to engage the community. Even now, in terms of menstrual hygiene, sexual reproductive health materials, we go to the community, for example, the schools, the different chief groups, and all that. So these are the people we engage with. And when we do engage with them, we sensitize them on the pros and cons, suggest options, and we design those options with them. Once the options have been designed with them, we move to a point of now implementing the change, the design, so that at the end of the day, we deliver on our impact. And that is what different organizations have been working on. So at the end, we have to look at it in terms of these are things that we used to do. They're not going to happen now. Sexual reproductive health policy research, deliberations, and lobbying should be going on, but not much is going on. For now, people are highlighting the challenges that are there, and little work is being done in terms of compiling the problems that we are facing as young people, the problems we are facing as sexual reproductive health advocacy groups. And when we don't have that kind of data research are being done, at the end of the day, we'll have so much to talk about, but little structures on how to follow it through to ensure we never go through the same problem again. So the question is, were we doing it right at this particular point in time? And if not, what can we do to make it better? So those are some of the things that we have there. Then now, under the SRHR operational workbook, the challenges that are posed, actually I've mentioned a number of them. Inability to access community to conduct health communication, school closures where people are getting the services. Informal sector workers are out of work, especially now the women. And most of the causes of gender-based violence, there's an aspect of dependence. So that is another issue that has happened, because most of the women used to be dependent on the men. When they were empowered financially, they were able to take care of themselves. Now they're in a point where they've lost their jobs and they have to go back to the point of dependence again. It means this person can abuse you, can take advantage of you, but you have no power to ask of what you want from him. Because at the end of the day, you have the question to ask: are you going to allow the person to abuse you and access your basic needs, and even your kids, for example, if you have a kid, or you're going to stand up for yourself and lose out on the basics? It means you might even die before every other thing happens. So that is a trade-off that people are willing to make. The financial constraints in families, people are not willing to buy sexual reproductive health right materials when they're not even able to get their food. If you have 100 bob, getting condoms from the shop, instead you can buy the loaf of bread for the family. Everybody would go for food first. So that is a trade-off that is being done. And with such kind of a trade-off, it means people are not going to access sexual reproductive health right materials. Sexual reproductive health materials, and when they're not accessing them, the risks that are coming with it, unprotected sex can contribute to. We have the issues on infections, sexually transmitted infections. We have risk of unwanted pregnancies, and all these are going to pile up. And then at the end of the day, after pregnancy, there'll be the psychological tantrums that come with it, psychological complications. You're feeling like you've been abused, circumstances were not right, you didn't want to have the kid, abortion, safe or unsafe. So it's kind of a cycle, a vicious cycle of challenges that are coming in, and we have to find a way to address them. There's reduced funding for SRHR related work. So most of the organizations are not focusing on funding SRHR that much, but the funds that are there are being repurposed to addressing COVID. And when the funds are repurposed to address COVID, the question is, what happens to people who had been dependent on grants and donor support? Do they need to work? And for them to work, they need the money. How do they do it without the money? So those are challenges that are coming. Stay at home, constrained with an abusive setting, and you escape, you are more at risk because you are now being exposed to the world. Those are all issues that we have. So what's the interface? How do we come in between SRHR as it is and then link it to the other aspect that we now have? SRHR as we used to do it, the current COVID. So most of the challenges that we had are being heightened because we can't give them the redress we used to give. So that is something that means we have to do more of our SRHR work. Even when we are repurposing and going into other areas, our core business has to be called the core business. Then new challenges that are emerging at this point in time we have the lack of social support or safety net, which used to be of help to these people. So when we look at it in terms of the challenges that are emerging at this point in time, social support and safety nets and the impact of marginalized, disenfranchised, and most vulnerable. For example, kids used to enjoy being in schools. Now they can't be in those schools because now schools have been closed down. It means they are more exposed again. Those are the problems that we're having. Two, some of the safety nets, we have the advocacy groups that were supporting them and taking them in. Now these advocacy groups can't take them in anymore. That is a problem that we're having. So many challenges with no support structure that is in place. And it means as advocacy groups, we have to find a way to be there for these people. And when we are there for them, we have to be able to address the challenges they're having and be there to make that difference as it's needed. So those are very critical things. Then we need to have versatile, flexible, and timeless projects which can surface in times of crisis. Most of our work, when people in the sexual reproductive health advocacy platform have been doing the advocacy work, it hasn't been looking at in terms of the crisis situation that might come up. So when we don't look at probable crisis that might be there, we look at it in terms of the current working structures. And then our programs are kind of basic in terms of what they need to meet at that particular time. But the question we never ask is, how do we do this when the circumstances are not right? And it means now moving from this point in time, we have to develop programs and structures that are now going to address such kind of crisis situations, pandemics that are going to happen and we have no control over them. It's kind of a risk mitigation plan. And those are things that we need to have. And actually in line with that, there is a Sendai framework that was established like 5 years ago. It got to the 5 years looking at in terms of supporting the vulnerable, the marginalized, and the disenfranchised group of people. But the question is, we are not adopting it because even accessibility and even like the penetration level of the framework has not been achieved. Not many people know about it. So when it caters for some provisions on sexual reproductive health rights and any kind of disaster risk reduction plans, then it's just in paper. Do we get to know it from the basics, the people on the ground, so that we can contextualize it, use it to formulate our action items? If we didn't have that, we are not going to be able to respond in a way that's going to favor our outcomes. So those are the key things that we need to look at as well. So that is the interface now. Challenges have been heightened. New challenges are coming in because we used to have the social support network. They're not there now. Our programs were kind of static. We need now to have flexible and versatile projects. Then now we need to adopting the disaster risk reduction plan. Most of their work has not been having risk mitigation, risk management plans. Now we need to put them on board. Then the next phase of action. What do we do now? So as any sexual reproductive health civil society organization, we need to start from a point of mapping our strategic focus areas of interest for the organization. As we mentioned, there are different focus areas. We can look at it in terms of, we've been working on access to contraceptive materials, menstrual hygiene materials, looking at gender-based violence, FGM, and all the other areas that are there. So which is the strategic focus area that you have to work on as an organization? What are your priority areas of focus during this period and time? So for example, if you're working on FGM, what you're trying as much as possible is to ensure no more FGM is working. You can't go to engage the community because most of them are now in the most left out places. So now on this particular point, what we now need to know is these two challenges are going to be there, and we have to find a way that we prevent it. Focus, for example, with an FGM will now to be prevent any probable chances of FGM being carried out. For the community mobilizing and everything, community engagement, that will come at a later stage because you can't do it at this point. Then, after you've known what your priority area will be, you move to the point of designing your theory of change, coupled with key action items and the performance indicator that you'll need to work with. So what's your theory of change? What kind of a change? When we talk about theory of change, we're looking at it in terms of what final goal do you want to achieve? Let's say, for example, I want to be able to make it achieve the goal is ensure there are no more FGM cases. I want to ensure every young person has access to sexual contraceptives where and when they need them without having to suffer any financial constraints. Then that is the goal. How do I get to that? Do we have people who can partner with us and ensure we have supplies of these? And once we have the supplies with us, how do these supplies get to the young people where they are, where they have to survive? Because we can't get them in the local, then usually structured system, for example, in schools where we can give them out to them. So those are the key action items we look at. How do we achieve that goal? And once we know how to achieve it, we've designed the action steps. What are the key performance indicators? Let's say, for example, we used to distribute 10,000 condoms within the universities. Now the next phase would be, can we distribute almost the same number in a particular community with particular number of people, for a particular number of people? If we give 10,000 within a university with 7,000 men, it means we had a supply of 3,000, depending on how they're using them. But if we're going to give the 10,000, we can't give 10,000, but he's in a community that has only 50 men. The point is, that is kind of, you're giving them out without looking at their use and the penetration, because we need as many people as possible to get access to them. So those are the key things that you need to look at. Then another component is looking at collaborative arrangements. That is where I'm looking at it in terms of which groups of people are allowed to access different places, which shops are open. So for example, I saw there's a model that is being adopted in the US. And in this kind of a model, you look at food distributor chains, and even now in Kenya, it's being adopted. Like food distributor chains are partnering with, distributors are partnering with hotels and restaurants and all that to distribute their food. And now civil society organizations have been used to feeding the vulnerable. They now come in and support in preparing meals within those setups. So for our case, what we can say is, we are in the sexual reproductive health space. We have pharmacies, we have hospitals and clinics that are open, and especially the hospitals and the shops that are around. Can we integrate our services into some of the essential businesses that are still operational in the area? So once we know these are operational businesses, we have, like, let's say, contraceptive materials, we distribute them through them, so that whoever comes in will pick them from there, give them out in shops, so that whoever comes, well, at the end of the day, we need to buy our food even when we're in lockdown. So when we go out to buy food, give them at least 2 or 3 packs of the condoms and all that. Chances of them taking them up will be high, uptake will be high, and it will also help us in reducing the kind of shame that comes with taking contraceptive material. They'll be available everywhere. When they're available everywhere, people are willing to take them up. People are open to discussing issues about sexual reproductive health, and that will be a way for us to bridge the gap and break the barrier that we've been having. And that will be a win-win for both of us. We broaden our perspective by looking at it in terms of what other services are being affected and how do these services get into a point of contact. Because when we deal with sexual reproductive health, there are issues on mental health as well that are coming up. So if these mental health issues are being brought by the sexual reproductive health, we need to broaden our perspective and look at how do we engage people in the mental health space. What support systems do they have in place that we can bring on board for our sexual reproductive health advocacy and sexual reproductive health work? Then once we bridge the gap between the two, then we are able to say our programs can withstand such kind of crisis, and they can't serve a community that doesn't have the initial support system. They will be sustainable, because after the end of the day, we look at it in terms of what issues are causing the SRHR complaints, challenges. How do these come to integrate with mental health? What support system can we address? For example, when we talked about financial dependence on men for women, now can we establish support system that will ensure women are financially stable by themselves without, even in times of crisis like now? If we do such kind of a project, they're able to run it by themselves, they're dependent, risks of GB will be reduced. And when gender-based violence is reduced, mental health consequences as a result of gender-based violence are also reduced. So it's kind of broadening our perspective of solving the social problems that we have as a society. Then the last thing, explore and leverage on available mediums, platforms, and avenues for the discharge of your mandate. There are different platforms you can use. We are using on Zoom. There are social media platforms that people can engage on. The shops that I mentioned in different platforms that people can engage. Once you're part of these, you get to learn and you get to know what's happening in the space. And by knowing what's happening in the space, you are better positioned to address some of the challenges that we have. So those are the key things that we need to look at. And I believe when we look at it in that perspective, most of the sexual reproductive health challenges that we're having as a society will have been addressed, and we'll be in a better position to respond to them and make a difference. So that sums up the presentation that I had for today. Maybe we can get to any questions that are there. We can have a chat before we end the session. So do we have any question?
I can take one.
Mm-hmm.
Hello.
Yes, I can hear you.
Yeah, and yes, we are talking about the access of the basic, this basic needs like the maternal health.
Yeah.
But I guess it should be something that that should be incorporated by all these people. Like we need the security forces who are enforcing the curfews. Yes, of course.
Mm-hmm.
And how can these people undergo it, and how are we going to take it this initiative to the grassroots? You know, yes, in the yes, we are talking about there are some places where there is no even communication, but these people have to stay indoors. How are we supposed to undertake this?
So in terms of ensuring services are accessed, but at the same time the curfews are enforced.
Yeah.
Okay. So in terms of enforcing the curfew, there I think it's through the Ministry of Internal Security. They've been doing their work. There's this kind of sensitizations and mobilization of the forces that has been taking place. So enforcing the curfew, they can do it, but the question is now in terms of their penetration to the local communities as well. We have a culture that most of our people are not willing to follow up on the curfew issues that are there as well. But then when we talk about accessing these other services, you know, there's a challenge that you want to access a service, but the curfew is enforced, so you can't go to the hospital. It's just the time that is allocated for that. But if you had an integrated system, let's say you have maternal health services, we have a common hotline that is redirected for such services. When someone calls for such a service, then it means they are able to be taken care of, taken to the hospital. And this now will come with the current passes that we are being given. There's the curfew pass that will show the kind of emergency you are addressing, and then you'll be accessed given the time to pass. But it all boils down to the social responsibility component. Because even now you find like police officers have been letting some of our ambulance pass through to go to the different places because they suspect that if for an ambulance, it has to be somebody who is in a critical condition and needs urgently to be ferried to a hospital setup. But what happens is our people are using these ambulances for fun. You take an ambulance to go out with it to party and all that stuff. So these are the points that we need to look at it in terms of, are we socially responsible as a society? Because if we are, we won't be having the same problems that we're having at this point. And even communicating these kind of interventions, it would be easier and it would be seamless. So that's what I think.
Yeah, I guess that's perfect, and at least if we take these through these measures, and if we create those whole the portals, the openness of about, and the people at grassroots are told about the importance to share out what they feel, what they share, and if we can create something that can be shared online, maybe a platform where people can share from their phone, at least I guess we can see this perception on a better end.
Yeah.
Yeah, sure.
Thank you. Any other question?
On my side, I guess that was my question.
Okay, thank you. Hezron, Mike?
I don't have any questions really.
Okay.
I just think you really covered it well.
No, thank you. So I think that will be the end of our session for today. For those who didn't join us, I'll share the link for the recording. Once we upload it, then we'll move on from there. And thank you guys so much for joining in.
And will you share the presentation?